Thank you, Abhijit. And once again, it's very, yeah. Let's see. Okay. Okay. Yes. Okay. Thanks, Abhijit, for the invite. And once again, I would like to thank all the people who are sitting here. Actually, it's nice to see the people sitting here for the submacular surgery when a lot of things are going on in the anti-segment. So, as usual, nothing to disclose financially. And submacular surgery is basically the blood which is present in the potential space, which is situated between the retina as well as the RP. There are so many causes which can lead to this particular condition. So, the earlier speaker, Dr. Barbara, was showing about the submacular CNVMs where she removed and transplanted with the RP. But nowadays we come across a lot of submacular hemorrhages, subretinal hemorrhages with the PCV, right, with or without treatment. Usually one of the goals of the treatment while doing a PDT along with aflibercept or ranibizumab is basically to close the polyp so that you will not have hemorrhage in those cases. And the other cases include trauma, angioid streaks, and when we are doing the surgery also, we can make some complication that can lead to submacular bleed, especially when you are doing a buccal surgery. Usually our drainage is a blind procedure. We usually drain the subretinal fluid with a needle. And if you do somewhere closer to the vortex vein, there is always a chance of the blood occupying the subretinal space, and if it's not cleared, then there is always a chance of poor visual outcome. And when you're doing a strabismus surgery, there is a chance. I have never done a strabismus surgery, so I don't have any experience in that. So we can have in a penetrating trauma as well as in a blunt trauma, you can have both the suprachoroidal hemorrhage as well as the subretinal hemorrhage in these cases. And RAM is other case where you will have hemorrhage in all three planes of the retina, intraretinal, subretinal, as well as the preretinal. So what happens? You should not allow the clot to remain subretinally, especially in case of trauma, to stay for more than 24 hours because all the damage to the retina overlying the clot over the macular area happens within 24 hours. That is because of the presence of iron and hemosiderin or the fibrin in the blood, which is toxic to the retina. And when the clot retracts, it can damage the photoreceptor as well as the physical separation of the retina from the RPE, causes atrophy of the both and can result in a disciform scar and poor visual outcomes. So when you come across a choroidal tear which is passing through the fovea just away from the fovea, if there is a hemorrhage subretinally, go for a gas injection, earlier the better actually. So there are various grades of subretinal bleed, right from 2 dd occupying the macula to the equator and more than 50% of the globe being occupied. Depending upon that, we can strategize our management of submacular bleed. So what are the good prognostic factors? If the patient comes to you with submacular bleed within less than 2 weeks duration or less, when you operate or when you manage, usually the outcome is good. And if the patient has got a very good vision prior to the disease, there is every chance that the post-surgical or post-management vision will be good. But if the patient has got relatively very thick blood at the fovea, if it is larger, if it is more than 3 dd, and the eyes with the AMD along with the membrane and the blood, and the hemorrhage of longer duration, that is more than 2 weeks, all these cases carry a very poor prognosis when you operate. So there are various options. I think something like TPA, Dr. Subhankar will be discussing. I'll just skip that. Injection of intravitreal gas with or without TPA, and we can just go for a pneumatic displacement with anti-VEGF. So we'll be talking about the blood clot removal surgically. Usually we go for a standard 3-port pars plana vitrectomy. Usually we use 23 gauge. And sometimes you'll have to convert to 20 gauge for 1 port because sometimes the membrane associated under the retina will be so thick, it's very difficult to remove. And usually then you go for the clot evacuation with the forceps or with the fluid needle, do a fluid air exchange and endo laser and treat it like a giant retinal tear. Usually you go for gas tamponade or oil. And usually the visual improvement happens in 30 to 50% of the cases, and complications include recurrent retinal detachment, PVR changes, cataract, and of course recurrent submacular bleed. So these things I'll skip because it's will be discussed by. So this is one of the case of a traumatic choroidal tear. And this is an indirect choroidal tear. We'll be having direct choroidal tear also. Direct choroidal tear happens usually at the site of the impact. Indirect happens concentric to the disc. And this particular person is fortunate because the choroidal tear is not passing through the fovea. If it passes through, then there is a chance of poor visual outcome. And they will go for CNVM also over a period of time, usually after 8 or 9 months. So in this case, we just injected the gas, made the patient prone. I think by third or fourth day, the blood has been removed from the macular area. Usually they will have a good visual outcome, but still there will be some scotoma. So this is one case where we can see a submacular hemorrhage. It's not very dense associated with the vitreous hemorrhage. This is one of the cases where we went in for surgery. So what we usually do is do a nice vitrectomy. We will have to induce PVD, and the induction of PVD should be up to the ora, because if you are going to create a retinotomy, there should not be any vitreous posterior to your diathermy or the sclerotomy you are going to make. If there is any vitreous posterior to the retinectomy you are going to make, then it's going to be disastrous. And we usually induce retinal detachment in these cases by injecting the balanced salt solution. Usually what I do is, it's an automated injection. I fill the silicone oil injector with BSS, mount it with a 44 gauge needle, and usually I inject the fluid in multiple places, at least 3 or 4 places, minimum 4. So what happens is, you can see the fluid when it is injected, you can see the retina being detached. It's an attached retina. We have to surgically induce the detachment. When you keep injecting, multiple bubbles form. When you do a fluid air exchange, yes, nicely all this bubble coalesce to have a nice detachment. So usually I go for a, that's how the retina is induced. Once it is induced, you go for a fluid air exchange, because all the fluid comes down, the retina detaches nicely. Then you diathermize in the periphery, closer to the ora. As I have told earlier, actually it's better not to have any vitreous posterior to the diathermy where we have done and where we are going to create the detachment. Once the diathermy is done, with the momentary vitrectomy mode, create a giant retinal tear. If it is more than 180 degree, it is peaceful for us to do the surgery. Once the retina is detached, fold the retina over the nasal side. We can find a nice membrane along with the blood. So you can remove that surgically. So in this, it's quite good actually. So we removed it with a forceps. What I usually do is remove this membrane, I put it on the nasal, then resettle the retina, and then start chewing the membrane. Literally, it is like chewing only. Okay, so there is some atrophy actually. We have not done any RP transplant. Once it is done, again you re-inject, treat it like a giant retinal tear. This is the first post-op day of this particular patient. I think he went on to improve only 6/60, and you can find some loss of RP in this case. This is another case with submacular hemorrhage, with subretinal hemorrhage, where we have again, and it's more of a membrane actually in this, as I've told already. So there is a membrane under the retina. Already the patient has undergone some peripheral retina because it was started by my fellow. So we are going to inject the subretinal BSS with a 44 gauge needle mounted on a silicone oil injector. You can find out nicely the bubble is forming. Once it is formed, in multiple places, do a fluid air exchange. Then as usual, the procedure is the same. In the ora, temporally comfortably, you make a nice retinotomy, fold the retina over the nasal part. I usually don't use PFCL while removing the clot. Maybe at the end we use. So in this case, you can see the membrane which is surgically removed is very dense actually. So as I've told, now I inject PFCL, settle the retina, float the membrane over the PFCL. As I have told, this membrane is usually very difficult. It cannot be chewed with the 25 or 23, so sometimes we will have to go for 20 gauge vitrectomy to chew that retina and remove it completely. Once it is done, go for a fluid air exchange and oil injection in this case. And this is the final outcome. This also not very great improvement, I think 6 to 36 or so. So these are the post-op pictures of some of the cases where we have done the submacular surgery. You can find out this is the temporal retina where we have done the retinotomy, and we have done a giant retinal tear which has been treated like a GRT. This is another case with subretinal bleed. So in conclusion, if you have a submacular bleed, the natural history shows a very variable visual outcome. Most of the time it is usually bad. So nowadays, one more technique what we are doing is, if there is only blood, there is no membrane, and if it is quite bullous, what I do is, after doing a vitrectomy, we go induce a PVD, inject PFCL, and make a peripheral retinotomy. The PFCL stays inside the eye for 3 to 5 days. And by the time, and the patient is made in supine position. By 3 to 5 days time, all the fluid, I mean the blood under the retina is expressed through the retinotomy which we have made peripherally into the vitreous cavity. And then actually after 3 to 5 days, we go for second surgery. During the time, we do the laser and remove the blood and replace, after doing the laser, replacing the vitreous cavity with the silicone oil. So in case of submacular hemorrhage related to CNVM, in AMD, it has got a poor prognosis, but if it is due to PCV, most of the time, the outcome is very good. So the adjunct of TPA cannot be underestimated, but the problem with TPA is cannot act in a blood which is clotted. Only if the blood is fluid, it will be acting better, not in a clotted blood. So with this, I would like to thank Dr. Abhijit for the opportunity. Thank you.